Good evening. Thanks, Martha. You were very kind with your words. I don't know that I can live up to all the things that you said, but I do have a practice with a lovely woman who's my wife, and we share a practice in a family health team in Georgetown, and I do, as Martha mentioned, palliative care as well as family practice, anesthesia. We deliver babies. Debbie does the pediatric consults in town. So we claim that we take care of people from birth to death. And that's pretty much it in terms of our practice. I'm also quite humbled in listening to the speech, the talk from Susan. I really enjoyed that. I thought it really did capture the whole essence of what we do in caring for people at end of life. It's a very special time, a time which many of us are frightened of, and rightfully so, because it's a difficult time, but a time in which many of us sort of enter with a sense that we can offer maybe some hope and some comfort and allow them to exit the life that we know with a sense of respect and dignity. And that's part of what we do in palliative care. And one of the questions that I was asked to deal with tonight also was, how does it differ? What's palliative care in the context of the disabled person? And I think that's something which I've had to sort of think about and struggle with, because in many ways, all my patients who come to end of life are disabled in one way or another. And it's just that they haven't had to live with that experience throughout their whole life. And they don't have necessarily the community around them like yourselves, who look after them so well throughout their lives and are so connected to them. Many of the people that I see are very much disconnected because their families are broken down, or because they've been left apart and not connected to the rest of their caregivers. So it's much, in many ways, I think there's more sense of hope for the people that are in community, where there are people that love them, care for them, and are willing to advocate for them, particularly in times of stress, in times when they are coming to the end of their life. So I'd like to speak a little bit about what palliative care is, and how we can service, how we can help, how we can provide some sort of guidance through that period of time, which is their end of life. I started off in practice in palliative care and became very interested in it because of the experience that I had with my parents, who died very early. They died at 62 and 63 years old of cancer, and it was not the most pleasant experience. Mainly because at that time, this was 30 years ago or so, there really wasn't a lot of organization in terms of care for the dying. There were oncologists who would do their best at caring for them, but their concern was mainly for the medical aspects, for curative aspects. And believe me, physicians are trained to cure, to help, and it takes a special type of physician who is able to remove the hat of cure and put the hat of care on, because it's a very different perspective that we look at when we look at caring for dying patients. So I know that it comes as something that's quite distressing to you as family members and as caregivers to have a member of your community who's seriously ill and going to die. And sometimes more so because you feel that they are not able to advocate for themselves in one way or another, whether they're language disabled or just too sick to be able to do that. So I encourage you as much as you can to do the work of advocacy for these members, because they do need your help in order to get through it. And I rely a lot on the family members to be able to go through that period in a reasonably seamless way. The whole goal of palliative care really is to allow the person to die with a sense of respect, a sense of dignity, without that loss of control that they generally feel, and in a way which allows them to live the best that they can while they're dying. Because really dying is just another aspect of our life. We are living through that period of time. And we need to give people the ability to live through that period of time with the best ability that they can. And seeing a person in the aspect of both of physical, mental, and spiritual, we have to look at all those aspects when a person is actually dying. So just as much as we do when they're living. And as I said, I think physicians sometimes fail in the respect that they put so much emphasis on cure and are unable to look sometimes at just sitting with that patient and allowing them to die with some sort of dignity. I always say that, you know, there's nothing special about a palliative care physician, except that I think they're more likely to sit at the bedside and spend a lot of time listening to the patient, rather than trying to endeavor, or at least trying to give the answers to all the questions. Because we know that we don't have the answers to all the questions. But we do know that in sitting and talking and connecting with a patient, we're much more likely to be able to offer them what they really need rather than what we want to give them. And I think that's very important to a person, to be able to feel that they still have a sense that they're connected and that the people care about them. Palliative care also requires, besides a sense of compassion, which is very important, but it also requires the time to be able to do that type of work, and it really means being able to sort of dedicate a certain amount of time of your day just to go out and have that interaction with patients or with the nurses. Because believe me, palliative care is not just a physician-oriented field. In fact, physicians probably have less to do with the actual patient care than anybody else. They may direct medications and things like that, but in essence, much of the work that I do is directed by the people that care for that patient directly, and that's the nurses, the physiotherapists, the social workers, the spiritual care workers, all those people, and you know, personal support workers. All those people do more for the patient than I really do. I can offer them certain things that will allow them to get through that period of time a little bit more comfortably. But all those other workers are so essential, and that's why we work generally in teams. Palliative care is rarely something that you can do on your own. There's just too many things to be able to do. So in terms of doing palliative care, we rely on the help of all these other people. In fact, just yesterday, we sat down in a group with the CCAC director, which CCAC meaning Community Care Access Center, which is the center point for most of the community workers, nurses, physiotherapists, all those types of workers. We sat with the nurses that were doing palliative care in the community. We sat with the spiritual worker. We sat with a student that's trying to learn a little bit about what we're doing. And we discuss all the issues to do with the patients that we have out in community. We also do this with hospital patients who are in palliative care units or in other units. And it's an important aspect of palliative care that we are able to use all those disciplines and talk about all the needs of the patient, because it's not just the physical needs that are important, but all the other needs. In fact, we sat down yesterday and talked about a young lady who I know from our church community, who has had the misfortune of losing her husband a few years ago, then developed breast cancer, and now has developed metastases to her brain, had radiation, and now is starting to deteriorate again. It's quite a sad situation. She has 2 older children, one who is off at university and now spends most of his time at university, and even on weekends won't come home. And her other son spends most of his time up in the bedroom. And she's losing her voice and is unable to call. And there are all these issues, and I haven't even seen the patient yet. And when I do go to see the patient, I know that the challenge will stand in front of me as to how to deal with all these issues, not just the issue of the physical health. In fact, in this case, probably the physical is the least important. The spiritual, the psychological, and the emotional dynamics are much more important. So I think when we talk about palliative care, we're talking about multidimensional care, and we look at the person as an entire person, and not just the physical disease or the symptoms that they have. How do we deliver palliative care? Palliative care is delivered in many different ways, in many different forms. And oftentimes it's delivered in hospitals, as you've often seen, either on an acute care ward, which is not the best way for it to happen, but on palliative care wards where there are specialists looking after the patient, both nursing specialists and physician specialists and all the other caregivers, make it so much more comfortable environment for the patient in hospital. So if you do have a patient, a person that you're caring for that is in hospital for an acute illness that is deteriorating, and we know that it's near an end of life time, then sort of asking to see whether they have a palliative care unit would be a very good place, or at least a good thing to do, because that's the best place for those patients to be. Besides hospitals, there are hospices, which are special homes where people can die very comfortably with lots of care, many volunteers, and community health workers coming in to look after them. And they're very special places, and you can find a lot of the information about these on the internet. And I'll give you a few websites afterwards, which will help you. The other place they can be cared for is at home. And for some people, this is a preference. For many of the disabled people that we're talking about, it's not really a viable alternative because of where they're situated and how much care it requires to look after those patients. In Georgetown, where I practice, I care for patients at home. Most of them that manage right to the end at home are men, because the women look after them. And that just is actually a statistic that's true across the world. And at times children can do that too, although sometimes that's such a huge emotional time that it's very difficult for families to do that. So, and it takes a lot of sort of organized care to look after patients at home, because there has to really be a physician available 24 hours, at least on the phone, so that you can deal with issues that may turn up at home. You have to be able to give those people support at home. So there are teams, even in Toronto, there's a Toronto Palliative Care Network that does do house calls and will deal with patients at home. If that's the preference of the family and the family member who is dying, then that is potentially a possibility, depending on where you live. We would like to see that throughout Canada, everywhere, but to this point, it hasn't been possible. We're dealing with that by educating a lot more physicians in palliative care, and hopefully that as time goes by, we will see many, many more people going into palliative care. I could go through all the things that we do for patients in terms of medical care, but I don't think that really is all that helpful. And if there's lots of questions about it, I can certainly help you. But I can tell you that there are many different ways that we can deal with certain issues in terms of the person's health. One of the main things that we do is treat pain, obviously. And I would say, as a palliative physician, is that pain is almost the easiest symptom to treat. We have lots of medications to treat it. We have many different ways to give those medications, from oral medications to patches that go on the skin to little needles that go under the skin and easily can be injected either by needle or by a little pump, which can be controlled by the patient or by a family member. So there are many ways that we can treat pain, and in most instances, pain can be relatively well controlled. It shouldn't be a cause for huge suffering. In some cases, it does become very difficult because of where the source of the pain is, particularly when it's a nervous system type pain. And in those types of patients, we often have to give them different types of medications, maybe even local anesthetics and epidurals and things like that. Those are but those patients are much more on the, we see we see very few of those types of patients. And most of the patients that we do see are the ones that are easily treated. They may not be adequately treated when we see them, and many physicians don't like using narcotics, but in palliative patients, it's good to give them medication so that they can live a reasonable life, reasonably pain-free. What we're trying and attempting to do is really to give them reasonable function, so that they're able to sort of live their life reasonably well. I have one patient at home right now who's a neighbor of mine, in fact, and she's an ex-nurse and very determined to be with it all the time, driving, doing all that stuff. She was found last year after having lung cancer, an operation. Her husband died the same day that she actually had a thoracotomy. She developed metastases to her bones. In the middle of winter last year, she was found on the porch because she had fallen and broken her hip and her ankle. And for 15-20 minutes, she was out on the porch in her nightgown and just, didn't know whether she was going to be able to make it through the cold. Fortunately, someone came by and was able to help her out. But I just sat with her yesterday night, discussing, what was happening to her. And now she has more metastases to her bone, but she wants so desperately to live a normal life, to be able to drive, to be able to get around her house. And she's starting to lose a lot of weight and she's getting radiation therapy right now. So we go through all the options of what she can do, what sort of pain medication would be best for her, how we can treat her nausea or constipation, all those sorts of things. And you come up with a formula that hopefully will give her what she wants. Now, what she wants is not the same as what another person wants, which is just not to feel any pain. She's okay with feeling some pain as long as she can get up and move around. So this is what the whole aspect of sitting, listening, and offering what is best for that patient rather than what is best for the physician or for sometimes for the family. It becomes difficult because we don't know all the answers, especially when the patient isn't able to give us a lot of information. How do we tell what they want? You know, when the physician at end of life comes and says, well, he's not drinking anymore, or he's not eating anymore, what are we going to do? Should we put a feeding tube in? Should we start an intravenous? How do we know if we can't ask? Sometimes we can ask, and we fail to ask. I remember when my uncle was dying, he had an ALS type syndrome, which is like Lou Gehrig's disease. It's a degenerative disease of the nervous system where you gradually lose power and function in your muscles, swallowing ability, all that sort of stuff. And he wasn't able to swallow and aspirated, developed a bad pneumonia, went to hospital. They put a tube down to help him breathe. And he was in the ICU. And they come and say, well, we're not going to be able to take the tube out, but we can always put a tracheostomy in and ventilate him and keep him alive. And my aunt was frantic. She had no idea what to do. You know, she came to me and asked as if, you know, I would know what to do. And I said to my aunt, I said, you know, there's no correct answer all the time. Sometimes you have to follow what you believe. But in this case, my uncle could still nod. He could still hear us. He may not have been he couldn't communicate in many ways, but when we sat and discussed with him and said, listen, you know, this is what's going to happen. We could put a tube down and keep you breathing and keep you going. Is that what you want? And he just shook his head. You know, he was ready to go. It was his time and he knew it. And we have to be able to sort of connect with the patient if they're able to connect with us. Don't ignore what their thoughts and what their will is in certain circumstances. It's always best to respect their wishes, and if you can get to what they want, then you can usually provide the best type of care for them. One of the biggest issues we do find is with hydration and with feeding in end-of-life care. And those can be very difficult issues because you're often confronted with the feeling that you're not doing the right thing if you don't offer food or drink. Let's face it, most of our social times in life are around a table. We sit, we chat, we talk. It's some of the happiest times of our lives, and some of the happiest memories of our lives is when we get together with our family and with this family member that's dying, or with this member of our community that's dying. This is what we remember. So when we think of withholding food, withholding drink to these dying members of our community, it becomes a struggle within us to allow that to happen. We in palliative care do realize, though, that when the time comes that they're not taking any food, taking any drink, that it's usually not very helpful to go to feed them or add fluid by intravenous. In fact, sometimes it does the opposite, but by allowing them to aspirate some food that's in their stomach, which they can't control anymore, or give them too much fluid that their body can't sort of deal with anymore. So I don't necessarily suggest that patients have an IV or are fed by tube. In fact, most of the times I suggest the opposite. There are certain circumstances where that's not the truth. You know, when someone loses the ability to swallow well before all the other things in their body fail. In those instances, you know, feeding them by tube might be the best thing. But in most instances, when the body is failing to the point where you're not able to swallow and drink or eat, then it's probably best just to allow the body to go through its normal sort of phase of dying. And that's but in the end, if the patient's family can't tolerate that thought, then I will start an intravenous, because for them, it would be intolerable to see someone die without that IV. So it's always a conversation. It's always a time when we can come to a consensus, usually without any argument. Our biggest arguments occur when some family member shows up from far away who's been out of the picture for many years and all of a sudden knows all the answers. And that's why it's very important, I think, that advanced directives are very helpful. And advanced directives really means coming to an understanding of what you want to happen near your end of life. So if you know, you may say in your advanced directive, I know I have heart disease and I know I have lung cancer. I don't want to have a tube put in. I don't want to be ventilated. I don't want those sorts of things to happen to me. And I think we respect those wishes, you know. And I think that's because one of the things that you don't want to do is find a patient wake up with a tube down, being ventilated, and that's not what they wanted. They just wanted to die with some dignity and not having all the machines around them. They just want to be embraced by their family. So I think we, in essence, what we want to do in palliative care is deal with patients in such a way that they feel whole, even if they don't feel well. In terms of a disabled patient, the other challenges we face is really understanding what they want, knowing what they want, and being able to deliver the care that they need in the place where they want it done. Sometimes we just cannot get that answer from them because they don't communicate well. Family members or community members usually have some idea of what's going on. They can be the advocate, and I really encourage all of you to advocate for the people that you know that are dying. If you think that something is happening which is wrong in context of that patient, then you should discuss it with the people that are involved. Sometimes it's a scary thing to speak to doctors about the care of that their brother, sister, community member is getting, but it's really important that you do that for them, because it's only through that conversation that you're going to be able to get something which respects the dignity of that patient. Those, in terms of the care of the disabled person versus others, I don't think there are many more issues, except, I mean, they have more bowel issues before, they're going to have them afterwards, and we have to deal with those. They often get ulcerations on their skin because they're often not very mobile, or they have contractures or something. So there are issues that medically we deal with. But I wanted really to touch upon what the soul needs, and how we need to care for these people in a very special way, respecting them as a whole person, as someone who is not coming to an end, but is opening a new door. And on that other side of the door, they're not disabled. They're whole people, and they will appreciate everything that's been done for them. So I'd like to end this with hope, in that I think that's what palliative care tries to bring, is a sense of hope for the whole end time for this patient, knowing that we're not only dealing with the person coming to the end of their life, but the beginning of a new one. One other thing I wanted to mention, I searched the webs to see what things that you could find in terms of looking for information as to palliative care possibilities for your loved ones. And I will leave some of these at the back. There's a Toronto Palliative Care Initiative. Most people here from Toronto, I presume so, right? Yes?
Yes and no.
In the case that you're not from the Toronto region, there's another several websites. The Ontario Palliative Care Association, OPCA, has a website as well. And within this website, they have a list of the palliative care initiatives. Each palliative care initiative is responsible for a certain region. For instance, I'm from Georgetown, which is the northern part of Halton, and we're part of the Mississauga-Halton LHIN. Okay, we're all in LHINs now, which are local health networks. So, so within this, I can find where I am. So I would look at Mississauga-Halton Palliative Care Network, and then who the chair of that network is and what phone number I can use. And so that way you can find the person you can contact who should be able to give you the information as to where you can find a palliative care physician, where you can find hospices, palliative care units, and how to contact the CCAC so that they can get nurses and all sorts of ancillary care for the person that's dying. So those are really important sort of information that you can get from the internet, which will give you access to all the care that's available. And fortunately in Ontario, each LHIN, each separate region has its own palliative care initiative. And so they will be able to sort of, to at least give you the information of what is available and maybe what isn't available. So, so I'll leave these at the back, and you can either copy down the information in terms of the website, or you can take one of these and use them to get the best care for your family member. Last thing I wanted to say too is we use a lot of sort of non-verbal aids to find out things about patients, like how much pain they have. Okay, so from white with no pain to red with lots of pain. And people that can't talk can sometimes still point to those. If they don't, they can sometimes use the little card with the happy face versus the sad crying face. And it's sort of an analog score. So you can sort of tell where they are and whether what we're doing for them is having any effect. So if you treat them when they're feeling like this, and the next time you go and see them, they're feeling like this, then you've done a good thing, right? And so we use these a lot, and the nurses, the palliative care nurses, usually carry them with them. And it's a good thing to use with patients who are more disabled and nonverbal, because they may be able still to be able to give you that information. It depends on, again, how disabled the person is, but oftentimes we can get some information from them, and those are just some of the methods that we use. I think I have now finished. Thank you very much.